Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information. And by the South Dakota Foundation for Medical Care, an organization working with the state's healthcare community to improve quality of care as part of the Great Plains Quality Innovation Network. Additional funding is provided by Aberdeen Asthma and Allergy, Avera Heart Hospital, Brookings Health System, Dakota Allergy and Asthma, Dakota Care, Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, South Dakota State Medical Association, Swiftel Communications, and Vance Thompson Vision. Closed captioning for On Call with the Prairie Doc is provided by Avera, Brookings Health System, and Fishback Financial Corporation. Like cousins growing up in different states, urban and rural healthcare are much the same, but different. Rural medicine, tonight, On Call with the Prairie Doc.
Good evening and welcome to On Call with the Prairie Doc. The practice of medicine covers a broad number of specialties. There's cardiology, oncology, endocrinology, pulmonology, OBGYN. I mean, it goes on and on. One specialty area that is particularly important in our region is the practice of primary care medicine, family physicians, rural medicine. Like all of medicine, it's undergoing many changes, good and bad. Closing of small hospitals and the effects of distance to health providers and patients, new technology, and of course costs. All of them impact how rural populations receive regular as well as emergency medical care. Joining us tonight to examine the state of rural medicine is Dr. Joy Falkenberg of the Custer Regional Hospital and Custer Regional Medical Clinic in Custer, South Dakota. She's also clinical professor of family medicine for the USD Sanford School of Medicine. Joy recently received the prestigious University of South Dakota Sanford School of Medicine Edward Batt Memorial Award for Outstanding Faculty Member. That's really great. Congratulations.
Thank you.
And so tell us a little bit about the Edward Batt Award.
I was kind of actually shocked because I was finishing up clinic and I was needing to get to the nursing home. I had a med student with me, so we ran up there and they kept paging me. And Dr. Brown told me I had to get to an architect meeting, and I was like, why does she keep calling me? I'm coming. So I kind of rushed down the hill and rushed into the room, and I literally like kind of bounced into the room, and there's all these people, and I was super shocked.
So, and the Batt Award is because you have been involved with teaching, but it has to do with bringing other doctors to the rural area, or what?
There's a physician that was an incredible teacher by his name, and he did that in his honorarium. And so you're nominated by students. I had no idea it was coming. I've taught students for years. I really think it's important. I mean, how are we going to get students back in those areas unless we act as mentors for them? And they should see through us, and they do see through you, that they want to practice medicine because what we have is so special with our communities. And I think clearly that must have shown through because I'm sure somebody, probably Ann Grady, helped out with that. I'm sure she nominated me.
Yeah, well, you know, and it's nice to have the awards, but the real reward is the joy that you get from those students when you mentor them, you know, and it's nice to be able to have something to share with somebody that's helpful to them.
Yeah. Yeah, I think that it's really important that somebody who's coming up in the young doctor world has a doctor who they feel like they can connect with and emulate, and that they really feel like they can connect with them, so that when times get tough and they think, wow, whatever, really? Yeah. Then they can call them, or they can pick up the phone, or they can email them. And we can help them get through those tough times.
So who was your favorite mentor? I know you've had, we all have several.
I have had so many people that have helped me, but Dr. Graber, who is my medical partner, is actually like my greatest mentor. He just is so smart, and I came to Custer because of that. But
And now and that was 2 doctors in Custer, and now there's how many doctors?
There's going to be 7 in October, and we help service Hot Springs, Newcastle, Hill City, and I'm just super proud about that. I should say Dr. Barch, who was a cancer care doctor, retired shortly after my medical school career. He was incredible. He ran the ethics board, and there's another one that he made me really think about, like ethics in medicine.
Yeah. And I think of Dr. Keller, an oncologist who had a beautiful way about him, and I also think of Dr. Walker, Ken Walker, who was a neurologist but an internist teacher who came from Emory this last month to be our guest on this show. So they're people that you emulate, but your parents are.
Oh, yeah.
Tell us a little bit about your mom and dad.
Yeah, so my dad actually wanted to go to med school and couldn't afford to go to med school, and ended up taking courses to get his PhD because he could work at the vet shop and shovel manure at the vet clinic and pay for it. But then he was a professor at Chadron State, and my mom ran the ranch. And my mom really was the silent one that now I realize was very, very important in forming how I interact. I'm much more like my dad. He's kind of loud and gregarious, but I want to emulate the person my mother was, like the quietness and how beautiful she was and kind to other people, and I try to be like her.
Like her, yeah, There it is. Well, we're here to talk about healthcare in rural South Dakota. We can talk about family practice medicine. We can take on any question of any kind. We can talk about any thoughts that anybody might have about any particular illness. So this is an important issue to be able to call tonight. You can talk about rural medicine. All of South Dakota is rural, with the exception of Sioux Falls and Rapid, probably.
Yep.
And so we can talk about that, but we can talk about anything, right?
Yeah, absolutely.
Tonight's Prairie Doc quiz question: medically underserved areas are areas designated by having too few primary care providers, high infant mortality or death rate, high poverty, or a high elderly population. According to the South Dakota Department of Health, of the 66 counties in the state, how many are listed as medically underserved areas? A, 27, B, 35, C, 49, D, 64. Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. I'm going to give you another copy of that book.
I'm excited about that.
We will announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answer in, but you can call in questions anytime through the whole show. We will answer your questions concerning rural medicine or any medical questions you may have as they are called in or sent to us via Facebook or email. Call in your questions to 1-888-376-6225 or send us an email on the address on the screen. So this show is your show. It's better because of questions, so make it better. Give Joy and give me a chance to try to answer your questions.
Yeah.
So you decided to practice in rural South Dakota because?
I wanted to make a difference for the people that I loved the most. And so I really, growing up as a kid, we didn't have doctors around there. We drove to Scottsbluff or we drove to Rapid City. And sometimes the care was good and sometimes it wasn't. Sometimes it was pretty choppy. And I said, I just don't want that to be the case. I think that if you go to Custer, you should be able to get care like you would get at Mayo Clinic. A doctor should know the difference between a cough from bronchitis and a cough from sarcoidosis. We should know the difference between bone pain from arthritis and bone pain from malignant multiple myeloma.
So let's just tell us about cough from sarcoidosis that just happened in your life.
Yeah, I had a PA student with me, and she was so excited. She's like, I have to write this down. It's the first case I've seen. But a super nice gentleman comes in, and I didn't know him from before, coughing, but something just didn't seem right, and his knee was really painful. And and it didn't look like a bronchitis. Did the workup, chest x-ray has a bunch of nodules on it. This is all in the walk-in, you know, and so I know I'm sometimes running late. This is why. But you got to do it right.
Did you hear that? This is why she's a little late sometimes.
Yep. But got him set up for biopsies, and it comes back granulomatous disease. And right, it's completely treated different. That's not treated with antibiotics. That's not treated. You know, you've got to do this right.
I remember the case of sarcoidosis probably 5 years into my practice. But it was another doctor sent it to me as an internist to try to figure it out. And it was either lymphoma or sarcoidosis. And it was sarcoidosis by the biopsy.
Yeah, right.
And it was just the Lake Preston person came in, got a little bit of a cough, you know. There's a lot going on in a practice that is wide open, primary care. Tell us, what is your average day, though? I mean, nursing home rounds, hospital rounds, walk-in clinic, your regular follow-up clinic.
Yeah, so I tried to get a little bit better work-life balance this last year because my kids are young and I wanted to pick them up at school. My husband's a judge and he works outside the home now. And so
he used to raise your children.
He used to raise my children, yeah.
But now he's the judge.
Now, right. He's out of the picture. So, not all the time.
Yeah.
But, you know, so I moved my appointments down to 7:30 because the kids I can actually drop off and they start school pretty early at 8. And I go throughout my day, and I usually get done at 3:30 to pick the kids up Monday, Tuesday, but then Wednesday is walk-in. And the patients start coming in at 7:30, and they end anywhere from 4:30 to 6:30, and then you're doing the ER that whole time. And then the next day I do clinic. So that's a 36-hour deal. And maybe you get some sleep, maybe you don't get some sleep. Fascinating, though, like you go from the walk-in, run upstairs, go to the ER. You know, maybe you have a cardiac arrest, maybe you have nothing. You know, it's just, you don't know. And that's why the wait times, right? You know, you can't staff something if nothing comes in and pay somebody to sit around to do nothing. You have to actually, in a rural area, you have to kind of say, well, we're not sure what's going to happen. You know?
And you don't know.
You don't know.
And you really don't have do you have a general surgeon there?
No, we don't have anything except for family medicine specialists. And I was thinking of you as an internist, right? Yeah. My internists are Dr. Brown, Dr. Waddell, and Dr. Graber. They're family medicine, and when I don't know, I ask them, you know? And we do kind of have this user group where we're like, oh, I have this hard case. What are your thoughts, you know? Right. And of course, the computer makes it easier with up-to-date and some of the great databases that now you can get on and say, now I remember this, but what are the other things I need to do?
Let's talk about the collaboration between physicians.
Yeah.
I mean, I find it a great deal of help to grab a doctor down the hall and say, you know, I've got a case. It's just, I had a case of a woman who presented with a severe pericarditis. I mean, it was just the worst pain. Pericarditis can be terrible. And she was just miserable. And of course, you know, well, I could just, it's pleuritic pain, chest x-ray is negative, oxygen sats are fine. She's just really hurting, and it's pleuritic. It's characteristic. You take a deep breath, you roll over in bed. I mean, it's the pleura, and I didn't hear a scratchy murmur, and I did the echo, and there was no fluid, but I knew it was pericarditis just by the character. And I ordered a Coxsackie virus titer, and then I looked it up and up to date, and I didn't miss anything. And you know, she would like a little reassurance. And so would I. So got a buddy of mine, and I dragged Dr. Bean in the room and said, you know, I'd like you to go over her and look at the record and look at tell me what you think. And he came back and he said, well, I think it's Coxsackie virus. Yeah. And it was.
Yeah, right? Isn't that great? And that's what we need to make sure we continue as physicians. When I was at residency in Rapid City, Dr. Rawson, Dr. Rosario, those guys were like just so helpful, and they were my pulmonologists, they were my critical care specialists, and I still call Dr. McCafferty and Dr. Rawson and say, can you look at a film for me? Can you look at this, and am I on the right track? Because they're so busy, they closed for a period of time, they couldn't take people. And so we're 8 weeks out, 10 weeks out, 12 weeks out, sometimes not available, you know. And so by the time I send a Parkinson's patient, you know, I've tried 1 or 2 meds already and made the diagnosis, and just asking for them to kind of to bless it.
And basically, that's kind of what you have to do. And families sometimes need to have someone else to bless it, just to make sure. And you can't blame them, and that's a good thing.
Yep, absolutely.
But the question I have is that how valuable is that collaboration between doctors? I mean, and how much does that happen?
It's irreplaceable. I think that we have changed how we've done things, right? With the hospitalist situation, that's something new in the last 10 years, would you say? And that's a little bit different thing, because you used to have your doctor, the doctor used to go to the hospital, and you kind of had this person who kind of knew you, or their partner knew you. We have to build the collaboration somehow really well between tertiary centers and the outlying doctor.
It needs to be better.
It needs to be better. We see the picture, and we need somebody to listen to the picture and say, I heard you, Dr. Falkenberg. I heard what you're saying, Dr. Holm. I will go through on my part and make sure your patient is taken care of.
Yes.
Yeah.
And that communication, and by the way, I found, and you should know, that this was when you sent her to my specialty clinic, this was discovered.
Yep.
And here was something that you might have considered next time that you would see something
Absolutely.
like that. So that we teach each other
Yes.
all the time. And that kind of
Constant
collaboration.
learning, constant learning.
Constant learning. That's why they call it the practice of medicine, something
Right.
like that. We have a question here. In fact, 83-year-old woman from Pierre, caller would like to talk about natural healing.
Oh, yeah.
Specifically, ginger root. Are there home remedies you like to present to patients?
I actually probably out of all my partners use more home remedies than anything else. And I think honestly doctors sometimes undermine patients unintentionally and intentionally. There are a lot of older folks that didn't go to the doctor. It was expensive. They knew how to treat some things at home. And I'm always kind of amazed that when kids pop into the ER, which is, $1,500, $2,000, and they haven't even had Motrin. And so, yeah, there are some things that I will use. I actually recommend, and I'll talk about echinacea. I talk about apple cider vinegar with people, tea tree oils for toenail fungus.
Oh, yeah, tea tree oil.
And I think some of those things are very beneficial. Lavender for sleep, especially you have a nursing home patient, and instead of giving them Ambien, giving them Benadryl, something that might make them confused, how about just a little lavender? And maybe it won't work. But maybe it will, maybe that little bit of lavender will help.
It's certainly safer than some of the medicines that we prescribe.
And ginger specifically, of course, for like OB patients and nauseousness it's
ginger.
great.
It helps for nausea.
Yes.
I am a vitamin D and a vitamin
Yeah.
B12 supplement kind of a guy, and I'm a big person into fiber
Yes.
diets. A 77-year-old man, caller, gets mucus in his eyes at night, and it turns into dirt. They say it's a dry eye, but caller puts sterile drops in his eyes with no effect. Discuss the difference in sterile water and drops for dry eyes.
So I suffered with dry eyes after I got a little bit of my LASIK procedure done, and I really probably didn't appreciate it as much until in the morning I woke up and it felt like I was peeling my epithelial lining off. I mean, it was really uncomfortable. And I found the thing that helped me the most was actually like the Sustain eye drops, because they've got a little bit of a thickness to them. They're not sterile water. You obviously buy them, but they're glycerol.
Yeah, they have some kind of a lubrication to it.
And so, Restasis is available by prescription.
You don't want to do the red eye out
Right.
constrictor
Like
thing.
the Visine,
You
over
don't
a
want
long
that.
period of time. No. But the Sustain was good.
I did read about eye drops or eye tears, real tears, and it's amazing what is in a tear.
It's amazing.
Tear has a lubrication.
Yeah.
It has drying and moisturizing. It's got protein that feeds the cornea. It's an amazing thing, and no matter how we do it, we're not going to replace
Right.
real tears.
The other thing the caller might want to consider is like fish oils. You don't think about systemic fish oils that you take in as a lubricant to the eyes, to the vaginal mucosa, to the anal mucosa as you age, in the elderly population, fish oils.
Well, that's icosapentaenoic acid, and the comparable to that is flaxseed.
Right, yes.
Flax oil, but I prefer the real seed because it also lubricates the gut and it fills the gut and makes the gut work. I like ground flaxseed, which is like fish oil, and flax makes the coat shiny.
Right.
I mean, it's that oil that brings everything to the rest of your body, and most of us white people have dry skin and
Yes.
could use all of the flaxseed or
Yes.
fish oil that you could use.
At my most recent, when I went to Napa to learn about healthy eating, we had flaxseed pancakes and they were incredible. And so I think sometimes you just have to introduce to people new ways of doing things, right?
That's right.
Yeah.
Incredible flaxseed pancakes, and it makes you a regular sort of guy.
There you go.
We often hear the old saw, safety first. But when you're in the midst of chores or you're trying to get something done quickly, it's easy to forget that need to take the necessary precautions. But it can lead to a life-threatening result.
One August morning, he was cutting down trees. Gordon climbed up on a large pile of the trees, and the pile started to shift.
And I jumped quickly, and my left leg got caught, and I hung upside down in a large timber, probably about 22-inch tree come rolling over me and pushed the chainsaw right down on me.
Gordon's jugular had been severed, and the damage from the chainsaw ran from his lip down to his chest. Severely injured, Gordon's first instinct was to drive his tractor the half-mile to his farm for help. Gordon made it to his yard with the tractor, and that's when his wife spotted him.
I looked out and it looked like he was covered with oil. And then I went out the front door. As I got out the front door, I knew it wasn't oil. It was blood.
Sharon helped her husband to the ground, and she knew she would need help.
And then I went in the house and called 911 and grabbed a stack of towels and went back out. And at that time, he was starting to gurgle. So I put him on his side and took the stack of towels and put on the jugular.
Police and an ambulance arrived, and in minutes, Gordon was en route to the hospital. He had lost so much blood that he barely survived the ride.
I was told they lost me twice, once on the way and then once at the hospital that they put the respirator on me. And
Dr. Chan Park was a surgeon at the emergency room the day of the accident. He says that time was critical in Gordon's case.
We tried to do it very fast and just control the bleeding and establish the airway, and we shipped the patient down to the Sioux Falls.
Gordon was sent to the Sioux Valley Hospital. He says that his wife's quick action and the wonderful care he received that day made all the difference in his life being saved.
I just couldn't believe it. I had no idea who I was going to get or what hospital I was going to go to, and the Lord and my doctors and local people in the fire department and EMTs and paramedics and emergency people and the doctors and my family and my wife and the Lord pulled me through.
Thank you very, very much for saving my husband's life. You've done a wonderful job.
And a few years later, the scars are barely noticeable, and Gordon's life is mostly back to normal. But he did learn many important lessons from that day.
That take time to be careful, and if there's safety equipment, make sure there's properly in operation equipment, and just slow down, you know, and do it at a slow pace and do it and get it done.
Well, that was a story from 2004. Little time's passed since, but what a great story. We couldn't not show it. Since then, many things have changed. Getting help quickly can mean the difference between life and death. Emergency care providers encourage you to have emergency contact numbers posted clearly for family members. For those of you with mobile phones, keep them charged and with you always, especially when you're working alone. So you've been involved with chainsaw accidents. Tell us a bit about that.
Yeah, you know, we have a lot of individuals from Hill City that are loggers, and so we have chainsaw accidents all the time.
What common?
Mostly they slip when they're walking and they cut their leg pretty severely. But the timber industry in general has some the vehicles will turn over when it's slick. The trees will come down, and as they're being felled, will hit people on the head and things like that. And in the new era of anticoagulants, you know, Brian, Jolene's husband, was gored by a cow.
Right.
And so out on Cooney Table, which is in the middle of nowhere. So
Cooney Table.
out near Pine Ridge Indian Reservation. And so that was the people that came in with Lifeline, saved Brian's life, along with Wes Suffolk, because he was the surgeon that we called. And I think that was a situation where Jolene obviously knew exactly how to get the GPS coordinates. The Lifeline came in and flew him in for surgery. It just missed the femoral by inch and a half.
Femoral artery in the groin. So Jolene, your sister who used to practice with you and now practices in Wyoming, why is she not here tonight?
Yeah, she's calving heifers, so she couldn't come with me. Which I'm not angry or upset with her, but I do miss her. She went to Lusk, Wyoming, and they're super lucky to have her. Frontier Medicine. They have some locums that come in the ER, but it's just her in the clinic. She's got a nurse practitioner that was helping her, and I think she had a family incident and is moving away. So it's different even than where I'm from. I feel so lucky to have all my partners. They're so great, and poor Jolene's out there just
all by herself. Lonesome.
Drowning.
Well, So let's hit some questions.
Okay.
Woman from Pierre, individual has acid reflux or heartburn or both, has been on medication for a remedy, is safe for an extended period of time. Okay, so it's probably the answer, omeprazole. Is it safe using it? What about baking soda, raw apple cider vinegar, a half a cup of water before meals and at bedtime? Is it safe to do that for an extended period of time rather than taking medication?
So I'm going to say a couple of things here. First of all, make sure what you're treating is acid reflux.
Right.
Heart can look like acid reflux. Ovarian cancers can look like acid reflux. So first, make sure that's true.
Esophageal cancer.
Right. And if you have recurrent acid reflux, the concern is esophageal cancer.
We're going to have a show on esophageal disorders in a couple weeks with Tim Ridgway.
Oh, he's great, yeah.
It'll be great.
I would say, though, I do actually recommend apple cider vinegar.
Do you?
Yeah, but I tell people, here's the situation. If you take it and you're taking 2 teaspoons a day and your reflux is under good control, great. I also recommend 20 pounds or 30 pounds of weight loss.
Yeah.
And some other dietary modifications.
I like lifting the head of the bed up by 3 or 4 books.
Yep. And unfortunately, coffee, big
avoid
offender.
The coffee. But my first choice, if I'm going to use a medicine, is over-the-counter Zantac, which is ranitidine.
100%.
And that's fast.
Yep.
It's not as strong, but it's fast. Now, she's on Protonix, she said, which is the same as omeprazole.
Yep. This can give you some diarrhea. That sometimes people get diarrhea and they don't think it's their proton pump inhibitor, or low magnesium, muscle aches.
There's a little risk for lung infections because it takes the acidity of the stomach that kills the bugs in the stomach, and then there's some reflux, and then you end up with an infection. But that's pretty low.
Yeah, and C. diff. I think about Clostridium difficile a lot anymore, and I see that on the boards they're starting to really ask about proton pump inhibitors and C. diff.
So, the point is that if you have acid reflux, or you have heartburn, or if you have new upper stomach problems, it could be a C. diff infection.
Yeah, it could
and then the treatment is 3 antibiotics and omeprazole in high doses for a period of time, and then you stop it.
Yep.
So that's a great question. And anything else, baking soda?
I think, just make sure that what you're actually treating is reflux. I do see some people, they think they have reflux and it's something else.
What counties are understaffed? Doctors, nurses, medical equipment? A lot of them.
Oh my goodness, yeah. I think that one of the hard things is that you have to almost get a doctor to get another doctor to get another doctor. And so in a situation like where we're at, I feel really lucky that we've been able to build upon success, and we can call our friends and say, I'm here, we're stable, please come. That's what Jolene's starting, it's like she wants to practice at Lusk. She's hanging in there, but she's got to get more to come and help because it's so overwhelming.
Right. So one brings more.
Yep.
And so there are a lot of underserved counties, though. A woman in 70, and that's our quiz question, you'll hear more later. Woman in 70 years of age from Mobridge has chronic bursitis, which means an inflammation of the bursa, or one of the joints, and pinched nerve going down the back of the leg. What can be done to help the bursitis and pinched nerve, because surgery cannot be done?
So I see this a lot. This is a common problem, back problems, of course, creating tons of problems in the United States. And I would say, that surgery really should be the last thing that people think of, not the first thing people think of. Weight loss, building the core, right, so that you're not taking up all this extra weight and your back's not hurting. Physical therapy, but then some medicines. anti-inflammatories, and I absolutely think everybody, if they have bad backs, before they do surgery, should try gabapentin or Lyrica, because they may be able to go period of 4 or 5 months and then not have surgery.
You know, they say that if you haven't lost nerve function,
Right.
that 80% of back pain will go away with surgery, and 80% of back pain will go away without surgery.
Yep. And what you mean by that, right, is foot drop, you know.
Yeah, you start losing your foot,
Exactly.
you know, you can't raise your foot, then you better get in.
Yeah, absolutely. I see a question here. Can I ask it?
Yeah.
Do you believe telehealth is beneficial in rural medicine? I have to give a little shout out here to Avera. Dr. Galal and Dr. El-Gahari have helped us recently with some telemedicine cases for hepatocellular carcinoma, CLL. Those guys...
Chronic lymphocytic leukemia.
Yes. They've been incredible. These are people that had a hard time driving over to Sioux Falls. They did a telemedicine in Hill City, and these people were able to do the initial consult, then they went over and received treatment. These are things we didn't have available in Rapid City, and I thought Avera really was very, very helpful. The University of South Dakota Sanford School of Medicine is expanding telemedicine. I'm unsure of some of those details, but I know this. I've talked to Brent Phillips, I've talked to our organization. We have to improve telemedicine, right? Because these specialists can come into my conference room and I can have things set up, and by the time they need surgery and stuff, they've seen the patient, we've examined them, we've gone through like a whole set of details, and we've got it worked out together.
You know, what's happened with the EICU is has allowed our community hospital that has an ICU to hold on to people that would ordinarily have to be shipped. And it allows our nurses to get better, the doctors to get better, the care provider, the whole system to improve, because we can take care of it in our local hospital.
That's
in fact,
great.
we've got a story that we'd like to share with you about it. An electronic intensive care unit, or EICU, utilizes modern communication technology to connect local clinics and small hospitals in rural locations to around-the-clock monitoring by specialists and access to additional resources of larger hospitals.
Well, the EICU is several things at once. First of all, one doctor and one nurse at the time, now we have 2 nurses, but sits at a central station of a bank of computers and has the ability to see the person on the other end, has the ability to see the electronic medical record on the other end, has the ability to see the vital signs and other monitoring equipment on the other end, and in fact it downloads directly to the computer. And so basically they're able to be in the room with their hands in their pockets. The cameras are 12 zoom cameras, and so you can basically examine the back of the eye from 100 miles away or further by using the cameras and their capability. The EICU is unique in that it's a continuous feed of data from every one of the patients at the bedside, and that data goes into the computer and is synthesized and evaluated constantly. Obviously the physicians are there, but if you're looking after 50 or 80 patients that are very, very sick, obviously you're not looking at each one all the time. So what the computer does is actually looks for trends, little changes in blood pressure or temperature or respirations and such, and gives the doctor a heads up then that this patient should be looked at, something's changing. And so again, kind of like a check engine light on your car, it says, hey, look at me. Maybe a problem, may not, but it deserves attention. We have a single EICU right now that serves 32 sites, I believe, at this time. And we're actually in the process of expanding that out to other regions of the country. Honestly, if you can put E in front of it, we're probably about to try it, but we've done E-emergency, and that's been probably the most successful. All of our critical access hospitals, or very small hospitals, actually have to have a physician to respond to emergencies quickly, usually within 10 minutes or maybe 20 minutes. The reality is if you're a single physician in a very small town, that means you're on call every night and every day for the entire year. It's basically impossible to do. And so what we've worked with the government on and other payers is that we can actually have a nurse practitioner or a physician's assistant located in the emergency room. And on the other end here, we have a board-certified emergency room physician and emergency nurses that are there to help them. So they basically just need to strike a help light. We come on immediately, and we can actually help the mid-level provider or the physician at that time to guide them through or give them any help that they may need with unique patient types in their area.
They're talking about 470 hospitals closing over the rural hospitals closing in the last 25 years, and a lot of them is because of that emergency room coverage and the trouble that emergency room might help. What's your thought on that? I mean, you spoke earlier about consults.
Right. One of the things is we have board-certified family medicine physicians as staff ours. And one of the things that Regional Health is doing to help us is a e-stroke. And so that when people come in with strokes, like for example, I had a patient who, Jane Doe, goes down in the park and she can't say or speak or do anything. They call me and they say, there's a Jane Doe that's here, looks like she's having a stroke. And I walk in and said, oh my God, this is my patient, you know, and she knows it, and she says, help me, you know, and we knew exactly when she went down. We got a CT scan, we knew exactly what happened, and we gave her antiplace to help reperfuse and break that clot.
Right, a clot buster.
A clot buster. But there's very specific criteria, right?
Boy, it's a very specific deal. Well, what happened?
She reperfused as she went to the ambulance to Rapid City. They called me in the ambulance from Reptile Gardens. She was 100% normal. I saw her 3 weeks ago. It's an incredible story. So what we can do is, we did that without eHealth, but with the e-medicine, with the stroke, we can have a neurologist looking, we can have an emergency medicine doctor helping, and I think it's better care.
I do too.
Yeah.
I think so too. I used to provide that same thing for heart attacks, but now there's a cardiology on the phone with me, sharing that burden, because there's a risk too.
There's a risk to it, yeah.
81-year-old woman from Wessington Springs. What do you consider high blood pressure? If blood pressure is slightly high, how do you reduce it without medicine? So let's talk about high blood pressure. And I'm going to say the first thing, make sure you don't have sleep apnea.
Oh yeah, absolutely,
sleep
right.
Apnea, that's a big hidden cause of high blood pressure and heart attacks and strokes, and it's 10 times worse than high cholesterol.
It's bad.
10 times worse than high cholesterol, sleep apnea.
I think that blood pressure has changed over the years, but the one thing I'm kind of surprised at with patients that they don't know is that there's not a constant with blood pressures, right? So like 20% of people in their 20s have high blood pressure, 80% right in their 80s. So because as our blood vessels get harder, there's more people with high blood pressure. Right. And there's confounding factors with blood pressure, you know, so you want to make sure that it's not just a one-time deal, you're not anxious when you're in with the doctor, but if you really have high blood pressure, right, it enlarges the heart. So if you don't do something about it, it's called the silent killer, because it ruins your blood vessels and you have heart attacks and strokes. It's bad. Right. So if you can do it naturally, here's what I tell people when they come in. I said, you know what? I see 6 blood pressures. They're all high. Let's put you on a little something, and you weight loss, control your sleep apnea if you have it, salt, low salt diet, exercise 45 minutes 5 times a week. You can try some hibiscus tea, avoid things like licorice. And if you do those things and you lose 25 or 30 pounds, we'll take you off your blood pressure medicine. Yeah. It works, actually. People who don't want to take medicines will do what they have to do. Right. Sometimes it works, and sometimes they just need the blood pressure medicines.
Yeah, but certainly what we used to say we needed to control is as a person ages, you get less and less tight, because we know that it's a J curve. You lower the blood pressure too high, and then mortality goes up again, or too low, then death rate goes up again. So the ideal blood pressure for an elderly person may be as high as 150 in an older person.
And it's somewhat like diabetes, right? You manage diabetes differently when people are 75, 80, or let's really look at it as what's the health of that individual, because a 70-year-old may look like an 80-year-old and an 80-year-old may look like a 64-year-old. You know, what's the life expectancy of them, and then decide how aggressive to be.
Right. We have an 84-year-old man from Hot Springs, South Dakota. Caller would like to discuss a hiatal hernia. What's a hiatal hernia?
Yeah, you know, so it's this outpouching. Well, it's a hole, like your whole
Stomach
thoracic
is partly
comes up into your thoracic area.
Yeah.
I had a woman that couldn't breathe very well, and people kept thinking it was her heart. And you know, and she's got all of her stomach up in her chest, so she's got like this much lung field instead of this much lung field. Unfortunately, there's not really good treatments for hiatal hernias, though. I mean,
no. And the interesting thing is that a lot of people who have hiatal hernias, which is that the stomach is pulled up by a shortened esophagus for one congenital reason or another, many of them have no symptoms or problem.
Yeah.
And many people who have reflux don't have hiatal hernias.
Yeah.
So don't confuse hiatal hernia, which is the stomach is partly up into the chest, to the real problem.
Yes.
The real problem, which is chronic acid reflux going up in your esophagus.
And now with patient portals and things, right, a lot of times physicians didn't mention something that they didn't feel was pertinent. So you may see it on your physician portal, you know, you got the chest x-ray result and there it says hiatal hernia. Why didn't somebody tell me that?
Yeah.
Well, because it really wasn't pertinent to what you were in for.
Because you have no symptoms.
Yeah.
You're doing fine. 83-year-old man from Sioux Falls. I have bladder and prostate problems. I've had a catheter for 2 months. Is there a stronger pill out there to take so I can get rid of the catheter?
Yeah.
That's a tough one.
That's a tough one because it's multifactorial, right? It's like, is the bladder neurogenic? Are the nerves working right? Is the bladder working right? Is it the prostate the really issue? This is really a complex one. I mean, because there's multiple facets. Usually just bacterial infections in the urine don't cause you to have a catheter. No. That's not why you have catheters.
This person had probably for years had a prostate that was blocking the flow. The bladder was dilated, never did get emptied, and its nerves got shot, and it got blown up like a balloon that's been blown up too high, too long, and it has no elasticity anymore.
Yep.
And so oftentimes these people just need to have a catheter. But it's no big deal. I mean, a lot of people have catheters and they live fine with the catheter instead of having these recurrent problems.
And what is a big deal is if you don't do a catheter and you back it all the way into the kidneys, and then all of a sudden your kidneys are shot, and you're in renal failure.
There you go.
That's a big deal.
That's a big deal. I have a sore throat and a nasty cough. Is there a home remedy that you would suggest? So let's talk about sore throat, the common cold.
Yeah. So I love this question because how many times do we see this, you know? And people come in and
a lot.
And the general sense is, I want to feel better, and silent or not so silent, I want an antibiotic to feel better, right? Mm-hmm. We know that in our country we're completely overusing antibiotics. We're giving Z-Pak for everything. It's just ridiculous. And there's very specific criteria. You know, if you have a sore throat that's isolated without a cough, and you have a fever, and you've got lymph nodes that are swollen and exudate on your tonsil, if you have 3 to 4 of those, treat it, fine. You don't even need the strep test.
No.
But if you have a cough, you're probably not going to have strep. And if you have a cough and a headache and a sore throat, and it's this time of year, and you have a fever and body aches, it's influenza, right?
Right.
And that's different. That's a virus. So viruses aren't treated with antibiotics.
Right. I've said it a few times.
I know. Home remedies, though, right? Saltwater gargles, ibuprofen.
I like throat lozenges because it makes saliva, which is a very powerful anti-infective agent.
Yeah.
So the classic cold is sore throat, ache all over, fever, and the beginning of a cough for 1 or 2 days, and then a cough for 2 weeks.
Yep.
And no matter what you do, antibiotics does not make it better any quicker.
I will tell you, I'd throw a little garlic in a pot with some chicken noodle soup that's made from bone marrow, and that'll probably do more for your immune system.
And what's more, people won't come near you, which is something they...
Yeah, that'll work.
My son had back surgery in November and still has pain. Should he have had physical therapy after back surgery or not? And should he start physical therapy if he's still hurting?
Yes, but this also opens a can of worms, right? The United States of America uses 80% of the oxycodone worldwide, and it's leading to addiction disorders. Don't use narcotics, people. Don't. It'll lead to an addiction.
So narcotics should be avoided. We're using too much.
Yes.
My watch just called me.
Yeah, I was
That's
interested
an amazing
in that.
thing.
It's not me calling you.
All right, so the most important thing for hurting in this person, I like gabapentin, and it's not a narcotic, and it helps. But I think activity is very important, and yes, he should have had physical therapy. Yes.
Should be mandatory after back surgery.
Absolutely. I've heard that stress can alter your health, and I tend to be a worrywart. What kind of problems may this cause physically to my health? Well, I think living is stressful. I don't care where you are, what you're doing. People are full of stress. In fact, I think it makes us stronger. In fact, bones are stronger because of stress. I think we overrate stress. Now, maybe this person is depressed. That's another story. What's your response?
So interesting, because I'm surprised you say that. I think people are completely stressed too. I think that cell phones add a lot to it. I think that the immediacy of things adds a lot to it. One of my favorite books is The Power of Now. And it talks about like not living and reliving the past, not going too far in the future. You got to live in the moment, and you got to let things go, people.
Let it go.
Yeah.
That's great. And now for tonight's winner of tonight's Prairie Doc quiz question. According to the South Dakota Department of Health, of the 66 counties in our state, how many are listed as medically underserved areas? 27, 35, 49, 64. What do you think? It's a guess.
49.
That's the answer. The answer is C. 49 of the 66 counties in South Dakota are considered medically underserved. It was Ruth Schoen from Sioux Falls, or Schoen, I think it's Schoen, who answered the question correctly. Thank you, Ruth, for participating, and a book will be in the mail for you soon.
Nice.
Joy, are you involved in the USD School of Medicine Farm or Frontier and Rural Medicine program trying to get rural doctors? Tell me about the farm program.
So I am not currently a site. Spearfish is a site. We kind of looked at that, and I take students each month. And so in that farm program, there's a student that's chosen to go to these rural communities for, I believe it's a 9-month period. And they immerse themselves into the community, and through that, hopefully fall in love with that community and rural life.
And stays.
And stays.
Or stays in a rural area.
Yep, sticks and stays. I like to think that I'm involved in a farm program myself, because I have a bunch of ranch experience, and I keep having this rural pipeline of kids out of Custer, Edgemont, Hot Springs area that I'm like, go to med school, go to PA school, go to NP school. Susan Anderson has helped a lot with the farm project, and so Bruce Voigt, Dr. Vogt. Incredible, right? Really helpful.
Really great leaders, aren't they?
Perfect leaders, yeah, and they're going to make that a great program.
I think, though, that my efforts through the years, like your efforts, if you keep trying to encourage students to enjoy the wonderful, the kind of life that we have in primary care, it's kind of hard to beat that. If they see the joy in our own lives,
absolutely,
they have to learn that that's the kind of thing to do.
We have 2 new doctors coming, and when we interviewed those, and they interviewed a couple different places, I took them to the grocery store, Lynn's Dakota Mart, and I took them up and down Custer, and I did not sell Custer to them. My people, my community sold Custer to them.
Yeah.
Took them to the greenhouse, took them to the taxidermy shop, and they said, this is where we want to be. We want to be part of this community, not just a doctor here, but like part of this community.
Let's talk about humanism and kindness in your practice, in your world, and in Custer and rural America.
Yeah, we've lost it, right? In society, at a huge level, at a macro level, and then on a micro level, we're too busy. We're too busy. We don't mindfully listen. And I would say the same is true for administration. Administration needs to mindfully listen to their doctors. They're saying things because they're trying to help. They're trying to help patients. And when we're in a room, I try very hard to pay attention. It's very hard with the computer and with people interrupting and things. But I would like to share that relationship with a patient where they're listening to me and I'm also listening to them. We're a partnership. This isn't me telling them what to do. This is us working together to improve their life and their lifespan.
Right, listening.
Yeah.
Probably the most important diagnostic tool. They say 85% of your diagnosis is made from the history, 10% from your examination, and 5% from the lab and the CAT scan and the MRI and all that stuff.
Yeah.
85% from listening to hearing the story.
We have to be like Sherlock Holmes, small details.
Listen to those details. So you also talked about mindfulness. Explain that mindfulness comment.
I have to say that I am kind of embarrassed to say I didn't come to this until later in my life. I mean, I'm 42, but I've done a lot of personal research in this over the last, 5 to 7 years. And I think it's one of those, again, back to the power of now. I don't want to live my life that I am waiting for the weekend and I'm waiting for Christmas break and I'm waiting for retirement. I want my life I want to be mindfully aware of when I wake up in the morning, what's my coffee feel like? How do I feel about the day? Is that the sunlight shining through? And even on your way to work, rather than having the radio blare, what's going on the way to work? Is that a flower blooming? And when you get to work, the same thing. How's my nurse looking? Is she sad? Is she happy? Do I need to say something to her? How about when we go into the room? Is that person, have they lost some weight? Am I connecting with them? Are they sad? Did they pause? Are they happy? And just being mindfully aware of others in your life and making an acknowledgement that the things around you are going on and are important. I try really hard. I'm not always great about it.
No.
But I try.
Well, and it brings joy to your life. We've got 5 seconds, final point.
Live life every day. You never know when it's your last.
We love it. We'll be right back after this.
As your baby grows, there are new surprises and adventures every day. With each new milestone, remember, immunizations are safe and one of the best ways to protect against serious diseases, especially between birth and age 5.
Now that my grandson Henry has reached his first birthday and our granddaughter Stella has arrived, we're making sure that they stay on their immunization schedules.
Schedule your children's immunizations today, for baby's sake.
Raised in the small prairie town of De Smet, South Dakota, it seemed natural and affordable to attend undergraduate and medical school in this state. Back then, as a South Dakota medical student, we all had to leave for our second 2 years of medical school someplace else. And I chose to go to Atlanta, Georgia, mostly to see what it was like far away and in a big city. I stayed there 8 years, the last 3 teaching, and came back with my Floridian life partner in 1981. That was a leap of love on her part, I should add. It's been 35 years practicing primary care internal medicine here. Soon, my job will change to a part-time educator researcher. And so in the last month, I've been referring my patients to other care providers. The exercise has been melancholy, filled with goodbyes and lots of fond, glad, and sad memories. This has highlighted in my mind the need for primary care providers in rural South Dakota, and everywhere really. We simply don't have enough family physicians and internists in our country. And as baby boomers are approaching old age and frailty, it's only going to get worse. In a recent report from the Center for Health System Change, they note rural areas have 53 primary care doctors and 54 specialists for every 100,000 people who live there. Experts say that's the right balance of equal parts primary care to specialists. But the problem is in the total numbers. In contrast, urban areas have 78 primary care physicians and 134 specialists. Better numbers, but overloaded towards specialists. What can be done to resolve this predicament? The rural dilemma answer seems not in salary. Maggie Maher, a financial journalist, said, "It's not about how much doctors make, it's about where they make it." Rural South Dakota may not be where the spouse, male or female, can get a job or wants to live. Maher explains more significant is the indication that many physicians are drawn to city-urban life for its anonymity and privacy. Patients know you professionally, but not personally. Just the opposite makes more sense to me. Medical practice in a rural area is better than urban because of the connectedness. It's about the relationships that develop within a smaller community. We see our patients not only at the office, but at the grocery store, football games, movies, and church. And it makes physicians more accountable, which is to everyone's advantage, really. Medical students need to realize this. I've been blessed and am thankful for a professional life just jam-packed with wonderful and personal connections. I wouldn't have it any other way. coming the whole way on your dime, and expertise in discussing rural medicine. Her enthusiasm about the subject is contagious. That does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people. That was great. Thank you.
It may only be skin deep, but its importance runs all the way through your body. The skin-body connection. Next time, On Call with the Prairie Doc.
Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, an organization working with the state's healthcare community to improve quality of care as part of the Great Plains Quality Innovation Network. Additional funding is provided by Aberdeen Asthma and Allergy, Avera Heart Hospital, Brookings Health System, Dakota Allergy and Asthma, Dakota Care, Orthopedic Institute, Physicians Care, Sanford Clinic Community Service Committee, South Dakota State Medical Association, Swiftel Communications, and Vance Thompson Vision. Closed captioning for On Call with the Prairie Doc is provided by Avera, Brookings Health System, and Fishback Financial Corporation.